Good evening. Welcome to Head to Toe with Dr. T. Thank you for joining us. We have a lovely topic today that could be painful to others. Some people could have been stigmatized, isolated, or embarrassed by having this condition. It's called epilepsy. Isifo sokuxhuzula. Isifo sokuxhuzula sithetha ngaso namhlanje. I am with my honorable guest, the head of family medicine, Department of Family Medicine at Nelson Mandela Bay, let me say, because all the regional hospitals are under him when it comes to family medicine. Dorangenja Regional Hospital, Uden Egg, and the district clinics. All things that say family medicine, they fall under Dr. Emmanuel Ajudua. Thank you so much for joining us. I nearly called you Prof. Maybe that's prophetic. You can kindly greet our viewers. Thank you for honoring us.
Thanks for having me, and good evening, viewers.
About family medicine first, let me just, can you tell me your sphere? What do you do? When you say family medicine, what does it entail? For a kid who's watching us, for someone who could be interested, for a young doctor who doesn't know which specialty to choose and so on.
Well, just to keep it simple, family medicine in other parents, they call it general practice.
Yes.
So to say, in other climes in Europe and America, they call it general practice, which general means you can do anything across the board. Maternal health, child health, adult health, what we know as internal medicine. Generally, anything that presents to you, you should be able to, depending on your skill set, you should be able to attend to it. But if for any reason the patients complain, is beyond what you can cater for, your facility cannot cater for what the patient is presenting with, it behoves you to prefer the patient. So basically, family medicine general practice is about everything, and it involves going through postgraduate training, residency training for 4 years before you can qualify to be a family physician.
Awesome. Thank you so much. That should actually clarify the issue and should be helpful for someone who's still debating which direction to go. Tonight we're tackling a very crucial and serious topic that is affecting a lot of people, irrespective of age. Let's just create general understanding for the normal citizen who's there. There could be health professionals, there could be people who are actually lay when it comes to medical information. What is epilepsy in simple, understandable language? What does it entail?
It's important because oftentimes there's a misconception between epilepsy and seizures, fits.
Sure.
It's important to be able to distinguish between the two. Seizure, on the one hand, is abnormal, excessive neurological discharges in the brain, all right? And oftentimes, individuals who have predisposition to having these seizures end up having long-term problem as a result of this. When they then have predisposition to it, it is now called epilepsy.
Okay.
So on the one hand, epilepsy, on the other hand, seizures. Seizures comes, that is the repeated discharge of electrical activities in the brain. It can happen just once off.
Okay.
It doesn't make you an epileptic. It's when you have up to 2 of it, 24 hours apart, and it continues like that, then you now say that person is epileptic.
Okay.
So that's how you distinguish the two. It's very prevalent. Globally, I think about 50 million people have suffered from epilepsy. And in that population, in the middle class, about 150,000 people per 100,000 population. In the lower class, in terms of economics, I think about 50,000 per 100,000 population are predisposed to epilepsy. Bringing down to South Africa, I think 1 in 100 people. If you have 100 people in a crowd, at least 1 is predisposed to epilepsy, to have epilepsy.
Can someone have a seizure and not qualify to be called they live with epilepsy, and vice versa?
Yes, like I said, if you have just one episode of seizure,
Sure.
it doesn't qualify you as an epileptic.
Okay.
You need to have had 2 or more,
Okay.
24 hours apart, before you can be, said to have had epileptic seizure.
I get you. This is like looking at the figures that we've just narrated. It seems it's a big problem. It's close to a health crisis, actually. Maybe we're not giving it as much attention as it deserves. What are the common etiological issues that predispose people to epilepsy? What causes it?
Well, it's varied, myriad of causes. If you look at it, things like drugs. It could be recreational. It could actually be prescribed medication that somebody is taking for some ailment in the body.
Okay.
All right. It could be infection. All right. Things like meningitis.
Okay.
And anything that can, affect the brain. Okay. It can be metabolic disorders, any form of ailments, hypoglycemia, hypertension, fever, and things like that. And then, of course, trauma to the head. All right, trauma to the head with toxins. All right, it can have I'm trying to keep it as
Simple as possible.
as simple as for the layperson to understand. It could be due to oxygen lack, hypoxia, and so on and so forth. Endocrine, hormonal disorders. It could be space-occupying lesion in the brain, and environmental factors. Things like alcohol, smoking, stress. Anyone undergoing psychological problems.
They can throw a fit.
Stress in the environment. Smoking. General environmental factors can trigger it.
I grew up in the former Transkei, that is the eastern part of the Eastern Cape. We used to see a lot of cases of epilepsy or seizures, and there was a lot of cysticercosis. Because people used to eat a lot of pork that is infested with tapeworms and everything.
True.
Is that still common in this region? Out of this,
exactly, it is in an environment where retroviral disease, HIV is prevalent. It is, an opportunistic infection. So when we talk about, space-occupying lesions and,
Sure.
it falls under that. Tumors, space-occupying lesions and infections, like neurocysticercosis.
Awesome. There's a lot of stigma attached to epilepsy, and there's a lot of isolation, embarrassment on the sufferers. We're gonna go through some of the issues, but just before we take a break, let's give hope or misery to the people who are watching. Is it curable?
Well, you find that of epileptics, all right, about 80% of people who have epilepsy tend to, at some point in time, stop having fits, all right? While at the other 20 to 30% would develop, chronic epilepsy, throughout their lifetime. So it's for some people, it's cured.
Sure.
For some, they will continue. For some reason, maybe they are not compliant with their medication, or the factor that, is causing it is there. Maybe there's a scar in the brain from a previous, cardiovascular accident, brain injury. There's some factors that cannot just go away, they are there. So those category of patients would probably continue to have, that is 30% or 20% that will continue to have, epilepsy throughout their lifetime, while the other 80% just stop, having, epilepsy.
I'm covered. When we come back, we're going to start on what is called febrile convulsions, because a lot of kids suffer through this and parents get stressed and so on. Just a touch on that when we come back before we get deeper into the topic. Mbukeli wethu, thank you for watching us. We're talking epilepsy. Dr. Judwa has differentiated between seizure. You can have an attack of seizure, but if it's repeated and occurs maybe frequently, more than 24 hours, or another episode of occurs of seizures, then it qualifies as epilepsy. There are a number of causes that he narrated. I'm sure you are listening. Inyame hagu namaqhakuva ndinathemba le nto banayeka. We'll be back shortly. Thank you for being with us. You can always watch us at Free Vision app wherever you are. Welcome back to Head to Toe with Dr. Tebelele. Thank you for joining us once more. You can always watch and follow us at Pile Communications, Pumakaba TV on all socials. We are live every Thursday. We're talking health from head to toe. Thank you. We're talking epilepsy today. We've differentiated epilepsy from seizures. Very, very clear. I've got a fundi here, the head of the Department of Family Medicine in Nelson Mandela Bay, Dr. Ajudwa. Sithela ngesifo sokuxhuzula. Isifo sokuxhuzula siyathanda uba sometimes ube nomjojo kawunaso ungafuna ukwaziwa netreatment ufuna uyityele ekhusini okanye uphela ungatyi kakuhle itreatment okanye uphela umixa itreatment notywala uzibalile izinto ezinobangela into yoba ube nesifo sokuxhuzula nezinosprovoker even if unaso utywala icuba izinto ezinokhula apha ebuchotsheni mhlawumbi unetyhuma okanye bubethiwe nobushushu. Talking about temperatures in babies, there's a lot of fears associated with the high temperature in babies. Can you just educate our parents about that, febrile convulsions?
Yes, again, that is one aspect that you cannot categorize as epilepsy because usually these children grow out of that, age when they are predisposed to febrile convulsions. All right, it's usually, as a result of spiking temperature occurring in children between the age of 5 months and 6 years.
Okay.
So outside of that age, fever may not be able to trigger seizure in that age group. You've got to look for some other possible causes for that. So basically what we do for them when they come in is we try and do what you call tepid sponging, a towel with just, water that is lukewarm, dump it all over the baby's body just by absorbing the extra heat.
Okay.
It cools the baby. I can also give some, benzodiazepine, a drug, Parectum.
Okay.
That also can help abort the seizure. But basically, what we want to do is turn the child on the left lateral side so that, when they fit, they don't aspirate their drooling, and because there's been reported sudden, death from things like that, whereby you leave them, you don't go close to them and see what is going to them, what is happening to them, and then of course they vomit, they secretions, and then they can aspirate in that. So basically, when they come in, we turn them on their side, and of course look for the cause. Oftentimes it's focus of infection somewhere.
Talking
Children,
about
they put in everything. Yeah.
Talking about aspiration, how do you tell as an ordinary person that this is a fit? Is there a difference between having a convulsion, or does every seizure continue to be convulsive? Or can someone fit without actually jacking and everything?
Oh yes. Convulsion varies. I mean, seizures vary. You can have what you call absence seizure, whereby the person is just staring without any, motor activity.
They're just like locking.
Oh yes, you can have that. Of course, between yourself and myself, in medical school, we talked about focal seizure, generalized seizure.
Yes.
In as much as the International League Against Epilepsy in 2017 changed, made it more complex in terms of the classification, where you now have focal, where there's awareness and loss of awareness. Okay. Generalized, where there's, awareness and, loss of, awareness, and all cascade of, sub-classification. So basically, you can have a seizure where there's just focal neurological deficit, but you are still aware of what is happening. But oftentimes, when it's generalized seizure, you are not aware of what is happening. So there are different categories.
That's awesome. What kind of investigations do you do before we're going to navigate a lot of myths around epilepsy to help a lot of people? As doctors, what kind of investigations do you do to come to the conclusion or to verify that there is a fit and then to establish the causes so that people are not alarmed when they are subjected to this?
Well, it will depend if this patient is presenting for the first time or a chronic, presenter, somebody who is known to be epileptic. If somebody is presenting for the first time, it's more tasking for us as clinicians because we have to go all out to investigate. Series of panel of blood investigations, lumbar puncture, CT brain, as the case may be. Unlike somebody who is known to be epileptic, but just coming in what you call a breakthrough seizure, which ideally we don't want them to come in with any fits at all. We don't want, in a period of 4 weeks to have any fits at all. But we often say, okay, 2-3 fits they're entitled to. But by the time they start getting more than 3 fits in a period of 4 weeks, it calls for, you to check their levels. Be sure that the drug level is within reference range, that they have not fallen behind or actually above the reference range, because patients can actually be fitting from toxic level of their medication. So for category of patients like that, we don't usually go all the way. We don't do LPs, we don't do CT scan. We just do the levels to see whether they're subtherapeutic or not. If they're subtherapeutic, we load them with the medication that they're taking. And at some point, we try not to, go beyond one agent. Some of them are, well controlled on monotherapy.
Okay.
Because we tend to say that new agents are epileptogenic. They tend to trigger new onset. I mean, you're talking about somebody who is having 3 seizures in a month and you're worried. By the time you introduce new agent without waiting to exhaust the maximum dose of the one agent, you find that patient who is getting 3 or 4 now starts getting about 10, in a month. So as much as possible, we want to be very careful when we introduce new agents. So new presenters, barrage of, investigations, including CT brain, LP, known epileptics, just do their levels, exclude triggers and all that.
Awesome. We're gonna hold it there and then we'll be back in a few seconds. Please don't run away. We're gonna be looking at a number of myths that are associated with seizures and epilepsy. Lots of beliefs, lots of attributes, and exactly what do you need to do when someone throws a fit in front of you. There are a lot of things that people do. Some are full of myths, some he will go through medically the advice or the first aid that you can tender on site. Stick with us, we'll be back shortly. Head to toe with Dr. T. Namkelekile kwakhona sithetha ngesifo sokuxhuzula namhlanje. Bonke abantu abaphila naso nabantu abanesa abantu abaphila naso, kukho into ethanda ukwenzeka. Umuntu abe embarrassed okanye afilishe small xa ethe wathrowa ifit in public, okanye afilishe into yoba esizigulo sami ingase singaziwa, aphele engazityi kakuhle iipilisi. Funa ukukhuthaza bonke abantu abaphila nesifo sokuxhuzula bayazi into yoba 80%, that is abantu abasibhozo eshumini bayakwazi unyangeka, aphela umuntu elibala noba wayekwanesifo sokuxhuzula, but 20%, that is ababini kwaba balishumi, iqhubekeke umuntu esibanazo isifo sokuxhuzula. Kubalekile into yoba utye itreatment yakho rhoqo and uhambe iziko lempilo for umane utshekisha into yoba kwenzeka ntoni, ii-levels zinjani na uDr. Judah uzichaphazele zonke ezo zinto. Nonobangela, i-stress, izinto ezinokhula apha engqondweni, ukuphazamiseka kwetyiwa ezithile apha emzimbeni, i-sodium, i-chloride, i-potassium, zonke ityiwa ezilawula indlela osebenza ngayo umzimba zinakuphazamiseka, nee-infections, uhlaselo lwentsholongwane ezithile like i-meningitis, zonke ezo zinto, ne-TB ezichaphazela ingqondo nomnqonqo zinakukwenza isifo sokuxhuzula. Ebantwaneni kukhona laa nto umntana beshushu kakhulu, uthi ke leyo into ayifolishi kule category, iyakwazi uhamba iphele, le nto sithi zi-febrile convulsions, ayilo hlobo lwe-epilepsy olo. But kubalekile into yoba once iqhubekeke laa nto, umntana atshekishwe into yoba awukho zinto ziphazamisekileyo nazinobangela into yoba aqhubeke nokuxhuzula. Enkosi kakhulu ngokuba nathi. Dr. Judah, there are a lot of myths, there's a lot of beliefs, there's all sorts of gospels that are talked about in the street about epilepsy. Let's start with what one needs to do when someone throws a fit. What should we do as ordinary people? I mean, we grew up with, no, put a sock on them on the mouth so that they don't bite their tongue and so on. What should we, and some say, stay away. If the person belches, that spirit will come to you and then will end up with fits and so on. What's your take on that as a health
See,
professional?
I don't completely blame the layman out there, because on one occasion, you know, because I'm a primary healthcare physician, so I go a lot into the, you know, community. On one occasion, I saw, you know, bunch of people running in one direction, you know. I mean, the first law of nature is self-preservation first. Perhaps I should have waited to ask what was causing the, you know, the race, and I took off as well. You know, in fact, it was a good test for me, because I didn't know I could run that fast. I overtook the man who initiated the race, only to then pause and what are you people running? What is causing the? They now said it was somebody fitting.
And you are running with them as a
I had to run first and then check, because if it's something that is deleterious,
Yes.
you know, or harmful, then I mean, so I had to now go back. No, you shouldn't be running that somebody is fitting. You know, they were all, like, very surprised that I could touch, I could turn the patient on the left side,
Good.
and everything. So I now, you know, tried some education that indeed this is what you should be doing, not on the right side, because between you and me, we know that at the bifurcation of the carina there, the left main bronchus is more angulated.
Yes.
Hence, secretions cannot go in there. So we turn on the left side, not on the right side. So I taught them all of that. I said, you know, I had gloves in my boot. If you are worried, but this is not going to harm you. You know, it doesn't make you epileptic if you touch, because that has been one of the, you know, problems that make people run away. You know, putting something in the mouth. No, you mustn't do that, because they have done all of that before I
No,
came.
this person is going to bite yourself or himself, and then they start pushing things in the mouth and so on. You say that mustn't be done.
No, you mustn't do that. They have done all that. Had to move up, you know, take out all the spatula and whatever they put there, turn on the left side,
Recovery position.
recovery position, and then of course call for the ambulance to take to the hospital.
And then the issue of can people living with epilepsy watch TV? And then what is the impact of bright light? Does it provoke?
Yes,
Seizures
some
and
people,
epilepsy.
it's not all epileptics, you know, that their seizure can be provoked by photosensitivity. All right, not all epileptics. Some people, a certain percentage, would be advised, especially if you have experienced it before, you are advised not to stay close to flashlights, you know, TV and all that. So it's not all epileptics that once they have had that episode, then you advise. You know, they present what led to this. That's why a very good history, you know, when you consult with your patient, it is important that you establish that this episode, what was the trigger, so that it doesn't happen again.
Fortunately, you are in family medicine. Family medicine teaches us to respect people's beliefs and values and so on. But there's this thing about epilepsy that people believe they have been bewitched to an extent that they want to go to traditional healers, faith healers, and then they either take treatment sporadically or don't take treatment at all, or disengage treatment altogether because they don't believe the way doctors are doing it, despite the explanation. But you've got epilepsy, it's caused by this and that, but they choose the other route. What can you say to those people? What lesson can you...
You see,
how do you handle such issues?
see, whereas other, with due respect, other, you know, domains, you know, clinicians would, you know, focus more on the clinical management of a patient. We as a domain, family medicine domain, we deal with not just the clinical, we deal with the individual, we deal with the context of the patient. So it is in that context of the patient you want to explore what is happening, you know, ideas, concerns, perceptions of this individual about the ailment. If you focus on just clinical, give your loading dose, you know, give your TTO medication, it ends there. If you don't address the context of the patient, you're going to lose that patient. Because it is the context you want to address, their belief, their perception, what is happening in the home front, so that you can talk them out of that very wrong perception that, you know, non-orthodox medication can cure them. You understand me? So we deal a lot with the individual aspect. We'll talk about lifestyle of the patient, alcohol, smoking, things that patients do that will contain triggers for the epilepsy. You address it. Context in the home. What is their belief, system? They must take their medication. Adherence is key. If you don't take your medication, you will keep fitting. There's no alternative.
That's like mixing your medication with alcohol. Can it be familial? If my brother had epilepsy, can I stand a chance to have epilepsy? Is it genetic?
There is
Should I be worried?
There is 30%, of patients who have epilepsy have first-degree family relatives who are epileptic. And there is an autosomal, manner of inheritance that with poor penetration, though, that is inherent, with epilepsy. So just 30% of it.
Because of time, just to wrap up, can you talk to people who are living with epilepsy as a family medicine physician? What young, old, and whoever, all the population that are living with epilepsy, just your last message to all of them.
Epilepsy, people should not be stigmatized to start with. People should see it as having hypertension, having diabetes, having asthma, and so on and so forth, having arthritis. Nobody should be stigmatized. And in the event you happen to be in an environment where somebody throws a fit, please, touching the saliva does not make you epileptic.
Awesome.
Touching the person does not spiritually transfer.
That's very important.
That person is not demonic. All right? It is just electrical activities in the brain that has led to that seizure. Maybe a little bit, elaborate more on that, in that you have the glutamate neurotransmitter that is, excitable, and there is no inhibitory fiber from the gamma aminobutyric acid. So that's where the treatment comes. You enhance the inhibitor and then try to suppress the excitability.
Awesome.
That's basically it. So that is what it is all about. Excitability, excess, no inhibition from the GABA, presynaptic neurotransmitters. That is what, the electrical activity is all about.
Dr. Judah, let me thank you so much. Thank you for giving us time. Thank you for the simplified lessons, and to encourage all people who are nursing and those who are living with epilepsy to understand the difference between seizures and epilepsy and the fit and also febrile convulsions. We are all clear. Let us stick to treatment, go for investigations. Don't forget to always honor our visits, check levels, and always don't mix a treatment with alcohol and any other thing that can actually drop the levels of the medication. If you are living with epilepsy, there is hope. There's hope of recovery, and there is one requirement we need: accept the diagnosis, and let us embrace all people who have got this condition, because it can affect anyone, because it's just excitability of the brain, as explained by our visiting guest. Thank you so much for being with us. Follow us on all our social media, Mpumakaba TV, head to Toe with Dr. T every Thursday, 7:30. We appreciate you.